Great. And I better unmute myself. Okay. Well, thanks everyone for joining us today. Julie, let me know if you can't hear me or anything, but I think we look good. I'm going to talk today about prescribing buprenorphine for chronic pain. And this is a hot topic in the sense that I think prescribers are looking for opportunities to offer patients evidence-based treatments for pain that might be safer than, say, C2 opioid medication. And so that's kind of where buprenorphine starts to be considered for many folks. And I think this is a medication that can be prescribed with, the medication can be prescribed potentially by primary care or by a pain management physician or provider. So I want to just talk a little bit about kind of why buprenorphine might be an appealing option in our talk today, and then also to address a lot of questions, because I think this is a kind of a novel molecule that maybe not all of us trained with. And so there are some points to discuss what are the unique qualities of this medication and the unique aspects you should know as a prescriber for your patient, just even to get it at the pharmacy. Let's see. Okay, and then here's our Max intro, which you've heard about. So if you have questions with your patients, feel free to reach out for this free service. We can discuss potential issues with substance use disorders and chronic pain management. So our learning objectives are here. Learners should come to describe the mechanism of buprenorphine and how that might be distinct from other opioid medications. And in fact, those, the mechanism really affects how it works for pain and the level of efficacy that we see. The clearance of buprenorphine also is unique, and preference for spinal opioid receptors has some bearing on its safety profile and efficacy. And then finally, I think, and this is one that prescribers definitely want to understand, what are the requirements to write this medication for pain versus to write it for opioid use disorder. Sometimes prescribers will assume if they don't have a DEA X number that they can't write it, but that's actually not the case, and we'll talk about some of those scenarios today. So I want to just start with kind of a caveat. So sublingual, so the audience here is presumably prescribers. Buprenorphine is a medication that is predominantly dosed in a sublingual fashion. So sublingual buprenorphine can be with or without naloxone, and it's primarily indicated for the treatment of opioid use disorder. So this is what it's been approved for, right, by the FDA. The approval is primarily around that. So what it's not approved for, like the 8 milligram generic buprenorphine tablet or film, those forms are really approved for opioid use disorder, and those forms are not really approved for pain. And so because that's the background of this medication in the US, many prescribers traditionally haven't thought of it as a pain treatment. But now I think we're starting to look at what are all of our options and fully explore these things and find what are some of the good options for our patients. What I would say though is please, if your patient has opioid use disorder, then let's focus on treating that. I do at times talk to patients or other prescribers where maybe if the patient's developing a problem with an opioid medication, oh well, maybe we just switch them to buprenorphine. But I think it's important to really do that in the context of like a full conversation of, what is the diagnosis, and does the patient have a diagnosis of opioid use disorder, and what are you treating? And while buprenorphine is maybe a safer molecule in some ways than a conventional C2 opioid, really we want to make sure we know what we're treating as much as we can. And so here's the slide that's really, again, if your patient has opioid use disorder, here are the benefits of getting them treatment, right? So if the death rate here of the general population versus in red here, persons with opioid use disorder getting no treatment versus persons getting medication-assisted treatment, obviously we're going to improve survival. So this is what's exciting about buprenorphine, is that it saves lives. I think there's a temptation maybe to conflate the effectiveness of buprenorphine for survival with pain relief effectiveness. There may be two different things, but certainly we know this is an effective medication that absolutely saves lives in opioid use disorder, and also, you know, can be an effective treatment for some patients with pain. I would also maybe add here, if we're going to speak briefly on medication-assisted treatments before we dive into really just buprenorphine for pain, that there are patients with opioid use disorder who do poorly on buprenorphine because they have a high level of pain. And some of those patients will do better on methadone treatment for MAT. And so that's kind of, again, the difference between maybe a C2 medication, the methadone, versus buprenorphine. So really what I want to introduce is just the concept that that may be the same for any patient, that any patient who you're thinking about treating chronic pain with buprenorphine, there will be folks that do great with it, and there will be folks that do better with a C2 medication. And that's really just the point that I want to get to here. So again, we're going to talk about prescribing for chronic pain and not writing buprenorphine for chronic pain if you really just think the patient has opioid use disorder. So I did want to bring this slide from a Lynn Webster paper of this year into this because it just has this nice little timeline and kind of remind us of buprenorphine as an analgesic and how it even came to be. So buprenorphine was discovered at Rickett and Coleman, which ultimately became Indivior. What I would say is buprenorphine is a thebaine derivative. So thebaine is a derivative of the poppy. So it's ended as a semi-synthetic molecule. So it's semi-synthetic. What does that even mean? That it started from a plant or a naturally occurring compound that is then manipulated and then becomes something else. And so that is the background of buprenorphine, that it's semi-synthetic. It starts with a plant ingredient and it's manipulated to make this new compound. Initially, it was developed for analgesia, and as you can see in the 70s, it was launched in the UK as an IV opioid analgesic. It was approved in the US initially in the 80s, was scheduled as a Schedule II opioid, and then not until later in 2002 were these sublingual formulations around and classified as Schedule III, and then around this time, of course, wider availability of these medications has followed for treatment of opioid use disorder. So then these last couple points are really around the newer on-label treatments for pain. So we're just going to, again, this talk, we want to talk about buprenorphine in general. I think we do kind of have to mention some branded formulations by name because that's some of what's out there as forms of buprenorphine that you can write on label for pain. But we'll talk also about just writing generic buprenorphine as well, because I think that's important to know about if this is something you'd consider as a treatment option for your patient. So again, these couple of on-label buprenorphine formulations for pain have been approved more in 2010 and 2015. The first was Butrans, which is a patch that's worn for a week at a time. It comes in strengths of 5 to 20 micrograms per hour. And then this other medication, Belbuca, which is a buccal film, that is dosed at 75 to 900 micrograms twice a day, generally. So I think this is the slide that comes to mind for a lot of us if we talk about, well, how's buprenorphine different than other opioids, right? We're talking about prescribing buprenorphine for chronic pain. There's no talk about morphine for chronic pain versus oxycodone for chronic pain. They're not that different. It's really more how any one patient reacts to any one of those Schedule II, and with the exception of maybe methadone and Nucynta that have some special mechanistic things, the rest of them are just not that different. And the response to them is based on inter-individual variability in opioid responsiveness to certain compounds. Buprenorphine, on the other hand, is a totally different molecule that acts differently and has different qualities. So probably most of us are familiar here with this idea on the right. I think that this full agonist type of opioid, morphine and methadone, have this dose response relationship, and there is at some point a ceiling effect-ish that the higher dose gets you less mu-opioid effect. However, buprenorphine is a partial agonist, meaning that it turns on the mu-opioid receptor, but more like, when I talk to patients about it, more like a dimmer switch where it just turns it partway on, and that's the way I'll tend to introduce it at times if that seems relevant to a conversation, that it's like a dimmer switch. It turns it partway on, but it really turns it on really well, versus I think the ups and downs that some patients will get taking a C2 opioid on a regular basis. So again, this is on the right is sort of the pharmacology of the molecule itself. And then over here is these side effects like respiratory depression, particularly just having being less problematic for patients taking buprenorphine because it even at high levels of this medication, respiratory depression and respiratory events from buprenorphine alone are rare. Respiratory events related to buprenorphine and ingestion of other medications, primarily there's, if a patient has a bad outcome, it is related to having other depressants than just the buprenorphine in the system. It would be rare for the bup alone to have that enough respiratory depression to cause that type of event. Okay. To continue on a little bit about the mechanism of buprenorphine versus other opioids, because it's just so unique, this is helpful. So this is a mu-opioid receptor. Can you see my cursor if I point here? So this blue guy here, the transmembrane pieces here, these are mu-opioid receptors. And here we show like a full agonist binding with a mu-opioid receptor. And then here's buprenorphine, like we said, partial agonist binding here. So it's not just partial agonist of how much it turns it on, but there are two pathways that a mu-opioid receptor activates inside of a cell, and they are a beta-arrestin pathway and a G protein pathway. And so it's actually this beta-arrestin recruitment that gives a lot of the negative side effects of mu-opioid receptor activation. That if you could preferentially activate just the G protein part, which comes over here and reduces neurotransmitter release and produces analgesia, those are a lot of the benefits of opioids. And if we could mitigate or reduce some of this beta-arrestin recruitment, this is some of what results in adverse events, including respiratory depression, etc. So again, and I think the figure illustrates this, but these P's illustrate phosphorylation. And so this full agonist produces more beta-arrestin phosphorylation and more beta-arrestin negative effects, versus buprenorphine results in less beta-arrestin recruitment. So fewer of those negative side effects. So just to summarize a few of those things, so this mechanism of buprenorphine is distinct from other opioids, and we've discussed that it may help its activity. It's a mu-opioid partial agonist. It's a mu-opioid partial agonist, as we discussed. Kappa opioid antagonist, which may have some benefits also in terms of mood effects, and beta-arrestin and G protein, I would say, in balance for the buprenorphine. Or excuse me, the balance is favorable. I would say that more activation of the G protein pathway versus that beta-arrestin pathway. So again, if we want to, so moving on to the second learning objective, we talked about the mechanism of buprenorphine as sort of unique from other opioids. If we want to talk about the safety of buprenorphine, is it the mechanism? Maybe, but also there are other aspects that contribute to the safety of buprenorphine for pain or for being preferred as a molecule for pain. And those couple of reasons are the clearance and then the preference for certain opioid receptors. So back to this kind of graph, a lot of times we think, oh, buprenorphine is safer because there's less respiratory depression, and that is part of it, but there's a little more, and that's kind of what we'll dive into for a moment here. So interestingly, as you probably know, there are opioid receptors in the central nervous system, in the brain, and in the lower central nervous system, which is the spinal cord. And the buprenorphine does seem to actually prefer these, some of these locations, these opioid receptors, more in the lower spinal cord. So there is more binding in these areas. They have looked at this in some animal studies in particular, where they have maybe administered buprenorphine to specific parts of the CNS or not allowed circulation in between, and the buprenorphine is able to have profound analgesic effects just by exposing it to the lower central nervous system, even without much exposure to the brain. And so then we also have to think maybe that could contribute also maybe to some of the less habit-forming or euphoric type of side effects, right? If it's more just in the lower central nervous system where, reflexes and pain and lots of important things are, but euphoria is not really down there. That's really more up in the upper central nervous system. And then I think to also kind of continue on about the safety of buprenorphine here, I did want to include this little slide to discuss the receptor binding. So this is, if you haven't seen this slide before, it just demonstrates, here's an MRI with some various slices through the brain and various concentrations of buprenorphine. And you may have heard various numbers put out as far as how many opioid sites in the brain are saturated by 2 milligrams of buprenorphine, or by 16 milligrams of buprenorphine, or by 32 milligrams of buprenorphine. And I think while you can get some different numbers from different studies, really even as much as 2 milligrams of buprenorphine in some studies may bind as many as like 40% of opioid receptors in the brain and central nervous system. And why is that important to know? Because that kind of tells you that 2 milligrams of buprenorphine might be a significant dose. If you can bind 40% of opioid receptors, produce a response, it may be sufficient for pain relief, in some patients, that you really don't have to have 16 or 32 milligrams in total saturation of receptors for a therapy for chronic daily pain, which is what we're talking about. So I did want to share a couple of pharmacology points as we're discussing kind of that safety and clearance aspect. So the clearance, there is that intravenous formulation that's really not all that available in the US, which would clear in just 3 hours. But sublingual or buccal formulations have a variable half-life, 24, even as high as 60. Most of the time you'll hear 24 to 32 or in the 30s, 36 hours quoted more so for the sublingual and buccal formulations that are more available. Now, naloxone, as you know, is present in some formulations of tablet or film buprenorphine, and it's poorly bioavailable. So if a patient were to manipulate a buccal film or tablet containing naloxone, what we know is that would potentially be more absorbed if it were taken by injection or intranasal. As someone who does prescribe buprenorphine with naloxone as a preferred formulation for my patients with opioid use disorder, what we do see the naloxone from patients taking it appropriately, sublingual or buccal, that does show up in urine screens. So I don't think it's correct to say it's not absorbed, but I think that it's sort of minimally absorbed, or it's not clinically relevant for the most part for many patients when they're able to take the medication. And frankly, I guess that goes for pain as well. If you had a patient that you were considering prescribing a sublingual or buccal formulation, I don't think you need to have any qualms about prescribing it with naloxone for this exact reason, that it has poor bioavailability. It will be absorbed. It will be in the patient's body, and it promotes abuse deterrence. Those are the advantages. But clinically, for most patients, it's very tolerable. Other considerations in terms of the safety of buprenorphine and any of that, those aspects that contribute to its clearance and safety. It does have some drug-drug interactions with the cytochrome P450, 3A4 inducer substrates and inhibitors. These products are not recommended in moderate hepatic impairment, and that's particularly relevant in the substance use population, where patients might be at higher risk to have certain hepatic issues but regardless of the indication, really those products aren't recommended if hepatic impairment is at that significant of a level. Certainly there are side effects to any medication, and for buprenorphine, headache, dizziness. Headache probably is the number one of a patient in my clinical experience. If patients maybe haven't been taking buprenorphine or started on a low dose, headache is not uncommon. And then some of these other side effects are frankly just opioid side effects, right? Dizziness, nausea, vomiting, constipation, sexual dysfunction, respiratory depression. Those are all just opioid side effects in general. And again, it's a Schedule 3 medication versus a Schedule 2, so you can put refills on it. It does have REMS requirements. The formulations of buprenorphine for opioid use disorder have REMS requirements relevant to opioid use disorder. There's, you may know, an appropriate use checklist. some things like that that are available relevant to those on-label formulations for opioid use with buprenorphine 2 and 8 milligrams, etc. The on-label formulations of buprenorphine for pain are subject to a different REMS requirement. They're subject to the REMS for long-acting opioids. So that Belbuca film, the Butrans patch, both of those are encompassed in that REMS for long-acting opioids. All right, well, and then finally, to get to kind of this third learning objective, let's talk about requirements for writing buprenorphine for pain versus writing buprenorphine for opioid use disorder. I think this is probably what a lot of folks are interested in, and we can talk about some about the clinical experience of writing this medication in my hands, and then also some of what's out there in the literature. So I would share that, as you probably know, that there is a requirement to use a X number, which is the special registration that one prescriber does with the DEA if you're prescribing buprenorphine for opioid use disorder. If you are prescribing a formulation of buprenorphine like buprenorphine 8 milligrams for opioid use disorder, this is on label, right? If you look in Hippocrates, whatever reference you like, the defined indications are listed there of what things are approved for. Those medications are for opioid use disorder. Now, what's interesting is that, just as a little reminder, so the medication has specific FDA approval for opioid use disorder. That doesn't mean you can't write it off label. So the on label requires the X number. Kind of this bottom point down here, we'll talk about off-label pain prescribing. I've mentioned already briefly these on-label pain formulations that have become available since 2010. So the one is called Butrans, buprenorphine transdermal film, which is comes in these doses. Oh, this is mistyped. It's actually 5 to 20 micrograms per hour. I'll fix that. So 20 mics per hour, just for reference, in case you haven't thought that out. So if you 20 times 24, so that's really just like 480 micrograms in a day. So like half a milligram of buprenorphine transdermal is the max dose you're going to get out of an on-label Butrans, right? 20 mics per hour times 24 hours, 480 mics, so not even half a milligram. Interestingly, in Europe, they have available Butrans up to 40 milligram strengths. I think there's some skin irritation associated more so with those higher formulations of Butrans, and so that hasn't been approved in the US. I have known prescribers to write more than one Butrans patch at a time to have a patient get 30 or 40 micrograms per hour, because again, even at that strength, 30 or 40 micrograms per hour, your patient's total dose in a day is going to be a half to 1 milligram of buprenorphine absorbed during that time, if you were, say, in the 20 to 40 range. And then Belbuca buccal film is the other on-label pain formulation that's out there. It comes in these various strengths, 75, which is really considered just a starting strength, more so for titrating. As I understand it, the formulations of Belbuca that were most effective in their studies were in the range of 450 to 600 micrograms twice a day. And so again, if you multiply this times 2 to think about your total daily dose of buprenorphine, 900 mics times 2 is going to be 1,800 mics in a day, which is 1.8 milligrams. So really just under a 2 milligram generic buprenorphine tablet. Dosed differently also. In the case, again, of this Belbuca buccal film, this is a twice a day indication. That's their suggested way of prescribing. Finally, talk a little about off-label pain prescribing. So buprenorphine indicated for opioid use disorder. Again, it's approved by the FDA. Part of scope of practice for a physician is to apply your knowledge to use the tools that you have in a way that's productive for the patient. Off-label prescribing is something that's been done for a long time. But I think the legitimate concern is, of course, wanting to also prescribe opioids appropriately. So why might this be a good choice? Well, first, what are the options? Generic buprenorphine tablets, so buprenorphine 2 milligrams or 8 milligrams. There's generic buprenorphine with naloxone, which comes in a tablet form or a film form. And then there's also the branded formulations out there, like Suboxone or Zubsolv that you've probably heard of, that could be used and prescribed off-label. Let's just discuss briefly kind of what that would look like to prescribe one of these formulations off-label. I didn't make a special slide about this, but what that really looks like is writing the prescription, maybe indicating on it the words for chronic pain, not including your X number if you have one, and then sending it off to the pharmacy. Now, I think in the real world, what happens very often in those cases is the pharmacy may call, because it's one thing to prescribe it appropriately. It's another thing for the insurance to approve it. So many, in my experience, some of the patients' insurances will approve it in the context of the X number, because it's buprenorphine may be approved for opioid use disorder, the F1120 diagnosis. So if the prescriber uses that diagnosis for, say, opioid dependence and includes an X number, then it's going to be easily covered by insurance. I think that's the other challenge with off-label prescribing, is that it may be less covered or not covered by the insurance. So I'm going to talk briefly about a couple of case studies. One is a patient of mine and one is not. I see a question about, is it bad to put your X number in a chronic pain situation? Yeah, that's a good question. I don't know that it's bad. I think there are a few factors. If you were someone who has an X number and was near your max, of course, we want to be compliant. We want to, only be prescribing to the right number of opioid patients. So if I had, 100, a waiver for 100, and this is my 100th patient, in that case, it might be bad if it was going to push me over that limit. I think sometimes patients, might worry about stigma, but, if they had awareness about, that somehow that X number was associated with writing for, that somehow that is if the X number is associated with writing for opioid dependency or opioid use disorder, I think that is a legitimate concern. But I see your follow-up question. So the question is that Epic won't let me send it without the X number. That's interesting. I think that's just probably, you're probably going to need to send it with the X number then, if that's all that your system will let you do. Because again, it's the same molecule, right? So the buprenorphine molecule here for this generic tablet or film. It's the same molecule as these other formulations, these on-label pain. So there's no magic that to prescribe any buprenorphine, you need that. That's not true, right? They don't make you get an X number for these on-label things. And in fact, in my pain management fellowship, and I'll date myself a little bit here, but I finished at Hopkins in 2008 with my fellowship. And at the time, we did write buprenorphine for pain sometimes, generally like 2 milligrams BID or TID. We got a lot of calls from pharmacies because it was so early. We got a lot of calls from pharmacies to explain what we were doing or why. And mostly with a conversation with the pharmacist, we were able to get that done or approved. So yeah, I think it's okay to use an X number if you have one. Obviously, you want to be compliant and not be over your max. But if you're a prescriber who has an X number and isn't overwhelmed with a total number of buprenorphine patients, I think it's very reasonable to use your X number to accomplish the goal, which is getting the medication for the patient. But it's just not strictly, truly necessary. And obviously, as we all know, pharmacies and pharmacists can adopt whatever policies that they want in the insurance companies. So we all have to operate in those environments as well. Those are the things where you might get pushback on that X number. So I just wanted to share a case study or two. One is a patient who actually was a consultation that we did through Max, where a prescriber had asked us about how to assist a patient. This patient with a history of Crohn's disease, who'd been on OxyContin 10 milligrams twice a day for some years, taking half a tablet at night, having difficulties filling the prescriptions, and wanted to transition to buprenorphine. The wife had a similar experience transitioning from pain medication to Suboxone and had done well with that, with fewer ups and downs, so to speak, getting on sort of a stable regimen of the medication. So we talked about, as the Max consultant, and I think this will be maybe my pitch too on what info you can get from Max if you reach out to us. We kind of talked through all the different options. So we talked about the Belbuca film as one option that you can use on label. There are some specific studies that that company has done looking at transitioning patients from even like MMEs, milligram morphine equivalents, over 90 down to buprenorphine, Belbuca 600 or so. BID with success, with some specific timing around it. But that would be one option, would be that titration down and some specific timing around those changes. Generic buprenorphine off-label, we did discuss that as an option. Thinking about what a good dose for this patient might be. And I've got a slide a little later where we'll talk about doses, a survey of prescribers done by the American Pain Society, which I think is just instructive to see what people do. We discussed a trial of what's an easy tablet strength to get buprenorphine, 8 milligrams, and to maybe take a half, or even better, to start as low as possible, even the 2 milligram tablet, titrating up to 2 to 4 milligrams twice a day. I shared that in my practice, we tend to use this F1120, which is an opioid dependence diagnosis, the way it looks on my EMR. I think different ones are different, that you might get different verbiage in your system, but for mine, this F1120 is sort of a non-stigmatizing diagnosis that really doesn't say anything about disordered use. And then I think the other thing we discussed in this case, and this is maybe part of the bigger picture discussion here today, is just to consider, would you go back? What if this doesn't go well? Certainly there are times that we have decided a patient has opioid use disorder and we want to transition them to medication-assisted treatment, and then the decision's been made, hey, we're not going back. That is not happening. That's not what's going to happen here. But for a patient like this, where this is an elective change, I would say that it helps me to kind of get my head around that up front. Okay, this is elective. This is, and having that discussion with the patient. Hey, we're going to try this, and set an expectation. Hey, let's try it for probably a month. I'd like for you to use it a whole month. Let's not just give up after a week if it's a little rocky. I'll even tell patients, hey, this may not be good for the first week or two, but stick with it, because I really want to see where you are in 4 weeks, in 2 months, those kind of things. I think setting that expectation, really letting them know. And if you feel like with a rotation, the patient might have some withdrawal, depending if you're putting them from a higher dose as they transition, just having a plan for that. Are you willing to write some adjunctive agents to help that patient transition? Having a plan around all that is super helpful. Okay, I wanted to share another case study of really a patient who, interestingly, came to me nearly on the regimen that we had her, that we're using currently. This is like a 50-year-old female with a history of gunshot wound. And she was treated in pain management for some years in the 90s and maybe early 2000s, had an intrathecal pump implanted, eventually had that explanted due to lack of efficacy, and weaned off of it completely. But in my mind, as a pain specialist, certainly anybody who's had an intrathecal pump has had their body at some point habituated to some pretty high physiologic levels of opioids. Again, even if it's not in your whole circulation, that your central nervous system has been exposed to some higher levels of opioids, which can be therapeutic and helpful for pain. But again, in this patient, it really was not, and she ended up discontinuing. When she came to see us, she was having difficulty maintaining her pain level, taking oxycodone, initially 5 milligrams, and then we escalated her to 10 milligrams up to 4 times a day. The next step was to consider, gosh, is this a patient that might benefit from a long-acting medication? But geez Louise, she's already been down this road and has tolerated, frankly, large doses intrathecally. What are our best options here? And so rather than going the direction of something very dramatic, we kind of started with this Butrans 10 microgram per hour patch. And I almost always start people off with the 5 and then increase as needed. It comes in 10, 15, 20. And that really, along with her oxycodone, has produced a big improvement for her. She has good pain control through the day and is much more functional. And she does report she's not having these ups and downs with the oxycodone the way that she used to. So I've been really impressed with this particular patient, like I said, in part because her background, is just such that she's had such high doses in her treatment in the past. This is the slide I wanted to share about some data from the American Pain Society. This was a survey they performed that they wrote up. I see your question about buprenorphine plus oxycodone. Yeah, we can talk about that briefly in just a minute. I just wanted to share this about buprenorphine dosages, how people dose it. So I think, again, this is survey data. There are a few more fields in the large table, but I kind of edited this down to what we would really want to look at. So how many of these prescribers have an X waiver? About 40-some%. What formulations do they write for pain? Bup with naloxone and bup without naloxone, or both. So most of these prescribers would say they write both of these, right? So we're talking about buprenorphine in all its various forms. And a healthy percentage write both, and most may write only this bup naloxone. Typical starting dose, most, more than half, right, starting with under 4 milligrams. typical starting dose, and then average dose would be, where do you end up? Maybe even up to 16 milligrams. And as you can see, under 4, 8, 6, 12, 6, 8, 12, 16. Again, I'll kind of make that point. The Belbuca and Butrans that are useful formulations, they're way under 4 milligrams, right? Both of those, you're going to get a 0.5 milligram or 2 milligrams in a day. So if you are looking at being able to offer a range of treatments, you might consider up to 8, 12, 16 milligrams of buprenorphine in selected patients that you are considering buprenorphine for. And then I think this is the other big piece. What are the buprenorphine management challenges? Switching to is the big one versus switching from or titrating. Just that switching to. So taking somebody maybe off of a full agonist opioid and then switching to buprenorphine, because generally the discussion is that the patient may benefit from being in a little withdrawal before getting onto buprenorphine. Okay, I think I want to just maybe next kind of address that question about how would it work. I'll look at the rest of my slides here. Okay. I want to address that question in regards to how would that work with buprenorphine plus oxycodone. So buprenorphine binds really, really avidly to the opioid receptor, right? So we've all heard, right? This is why you don't, this is why a patient needs to wait to be in some withdrawal before they take that first dose of buprenorphine if they want to be induced, right? It's because it binds so avidly, and then it's a partial agonist. So once it binds, it's not going to be turning on that opioid receptor all the way. It turns it on about halfway, partway. So back to the slide with all the brains on it. So these low-dose formulations of buprenorphine, like the Belbuca or the Butrans, are kind of in this level where you're binding avidly, like 40% or less of the opioid receptors in the central nervous system. And so you've got 50 or 60% left that are available. And so that's kind of what I would say, how does it work for like a pain regimen that might include a short-acting C2 and a low-dose buprenorphine. In my hands, I don't do that with buprenorphine 2 milligrams or buprenorphine 8 milligrams, because then you're kind of at these bigger amounts where there's just going to be less opportunity for a C2 to do any good. But for those on-label formulations that are for pain, in my hands, we do have some success, and other pain providers do this, where these on-label formulations where you're binding 30% of your mu opioid receptors, and so 70% are still available. It can be reasonable to provide a couple of doses, 2, 3, maybe 4 at the max. I guess my example was 4. Ideally less, really. I mean, if you're right, if that buprenorphine is really effective, maybe you can, step down into that 2 or 3 times a day for your short-acting med. But that is kind of what that looks like. And again, I think particularly with those on-label formulations, I think that's within reason. I think it's might be a little more on the edge if you were writing, 2 or 8 milligrams of buprenorphine. There may start to be less of a rationale if all your opioid receptors are already saturated, then what's that other medication for? But at these low doses, there's a real clinical rationale, and we do see effectiveness of it. I'll just run through these last couple slides and we'll finish up. We did talk a little about conversion from high and low MMEs. This was these are some charts in relation to rotating. So say you are considering rotating a patient on a higher dose therapy, so more than 90 MME. So, and here are some examples of what that looks like and how you might do that. Starting buprenorphine 4 to 12 hours after discontinuation of the full agonist, starting with either this high level patch or 300 mics subbuccal buprenorphine BID, and trying, again, this with some of these conversions initially, see if you could titrate a patient even on this 90 MMEs or more. We have had some success titrating to even these on-label formulations, 300 to 900 micrograms of buprenorphine BID. Had some success getting patients there. And often it is for a motivated patient, someone who sees a benefit or advantage to this different kind of medicine. The other pitch, if anything, I'll give a patient, if we're talking about rotating to one of those, is even, hey, I can give you a refill on that. Some of these patients I might see on a low dose pain formulation, 2 milligrams buprenorphine or less. I might see that patient every 2 months if they'd never had opioid use disorder. There are some patients like that in our practice that we'll see every other month. So I think we'll kind of wind this up, and we'll share this that in terms of these learning objectives, hopefully we've reviewed that buprenorphine has some distinct mechanism of action, different from other opioids, and that may help some of its effectiveness for pain, right? The way it affects the G protein receptors, the way that it works as a partial agonist. It doesn't actually mean partial pain relief because it binds so avidly to these receptors and leaves them on a long time. Partial agonism is not partial pain relief. The clearance of buprenorphine and preference for the spinal opioid receptors may actually be good factors in its safety profile, and maybe in the analgesia as well for those spinal opioid receptors. And then finally, we've talked through some of those different requirements for writing for pain versus for opioid use disorder, and how you might use really any of the FDA approved formulations for pain. Hopefully you have a little more understanding of that, and I'm glad to answer any more questions.
Thank you, Dr. Merritt. I do see there are a couple of questions in the Q&A box. If you are able to access those. If not, let me know and I'm happy to read them. And everyone else, you can also feel free to questions in the chat box as well.
Okay. I may need you to read.
Yeah, absolutely. Let's see. Okay. So the first one that I see here, when prescribing for patients as treatment for OUD, can those with an XDEA also prescribe buprenorphine for pain? For example, if you are the patient's PCP or only seeing for SUD management, is it okay to in a person also OUD treatment?
That's a good question. I mean, I guess, are we talking about a single prescriber, right? Like if you're the, or are you talking about someone who maybe was getting, oh, well, I've got, Suboxone from my, MAT provider, would you give them additional buprenorphine for pain? I guess I have more of a framework in that OUD, in that opioid use disorder patient. I have more of a framework like methadone, in terms of really just like, well, why not just push that dose of buprenorphine? Why not have that one person who's prescribing it push that dose? I think that makes a little more sense to me. And I guess it's just because I do have that little bit of hesitancy around, obviously there's potential for, scrutiny and review of any of us, prescribing opioids for pain or other reasons. We want to always be doing it carefully. So I guess I would be a little less inclined to, be a second prescriber on top of somebody else's buprenorphine prescription. I think, again, the risk is it looks concurrent. It looks like you're not paying attention. It looks like you don't know. I probably wouldn't do that, but I might talk to the other prescriber about could they increase the dose, or there are a bunch of adjuvants and another, a bunch of non-opioid adjuvants that could be tried.
Great, thank you. Another question I see is it recommended? Oh, sorry, just moved. Is it recommended that the patient get detox from buprenorphine instead of stopping abruptly?
Okay. Yeah, that's a good question. In my, what I can say is, I haven't had, so I do write prescriptions for buprenorphine for opioid use disorder and for pain. And I have, for those pain patients who are getting an on-label formulation that's, again, equivalent of 2 milligrams or less, for those people who, I can just share my clinical experience. For those patients who are a pain patient using their medication appropriately, taking 2 milligrams of buprenorphine or less, I have people just stop that cold turkey and it's fine. It just, they'll just do it and they'll just tell you, oh yeah, I stopped taking that. And it doesn't seem to present big problems for that, for those patients. I think I don't have anyone stop 8 or 16 milligrams of buprenorphine and say it's no big deal. That's just doesn't happen because it's, your whole system is saturated. You've got 60, 80, 90% of your opioid receptors saturated all day, and then suddenly they're not, and it's a big deal. So I think it depends on your dose, maybe is the answer. So whatever the indication is, anybody who's on 8 milligrams or more probably does need to titrate to off. And with the pain formulations, I kind of have a clinical discussion with the patient based on their experience. Oh, this is giving you some side effects. Well, then you could probably just stop it. Or sometimes I'll tell them take half the dose for a period of a week or two. Would be like an intermediate advice, depending on, the discussion I have with the patient.
Great, thank you. I do want to be mindful of the time. I do realize it's 1 p.m. There are still some questions in the chat. So Dr. Merritt, I'm not sure if you have time, and if not, I'm happy to tell you the questions and follow up as well.
That'd be fine. I have a minute, so I can say for whoever wants to listen, and we can, I guess it'll be on the recording, and, we could even jot some answers down.
Great, thank you. Just one question. Someone was wondering if you can go back to the slide with titration. If there is more of a question with that, you can feel free to let me know. But there was also another question in the chat asking, are there any issues with skin adherence when using the Butrans patch during the summer, either from perspiration or from water?
I have, interestingly, the Butrans patch is a week-long patch. I had actually looked this up because I had a couple of patients who were women of color who had reactions to Butrans around the same time, and I found it like a little concerning and surprising, so I ended up doing a little reading. And I think that is more common actually for people of color maybe to have some reactions to this particular adhesive. And it's extremely adherent, that it's a week, right? The fentanyl patch is every 3 days, right? The Butrans patch is a whole week. It's a long time to wear a patch. So it's pretty adherent, and I don't hear as much complaint about it falling off as we all have with, say, the fentanyl patch. If you've ever written a fentanyl patch and talked to someone about it, they're pretty adherent, and almost the complaint is they're too sticky. It irritates my skin. I can't tolerate it. That's more what I hear.
Great, thank you. Another question we have is, do you have any tips on dosing, schedule, and doses for folks for OUD?
Dosing schedule for OUD, like somebody, with like pain and OUD. Okay, right. I mean, certainly, we'll suggest patients can, split doses. I think a lot of that framework comes from methadone, right? Where methadone is metabolized and there are certain metabolites that develop over time. And the idea is if you could have this split dosing, you might get different benefits. I think with buprenorphine, certainly the training that I've had is yes, that you can dose it 2 to 3 times a day at least to get some of those pain benefits. Realistically, you're not going to get a pharmacy approved through a prescription approved through the pharmacy for like 4 doses of bup a day. It might make more sense to say, take your 8 milligram film, cut it in 4 pieces. You can take those through the day. If for a patient with pain, if we're real, probably there is a certain amount of reinforcement that's happening just from taking that medication over and over, and that's negative for some people. But on the other hand, it could be a strategy at least to try and see if it's effective.
Great, thank you. There's 2 more questions. One is, in patients on buprenorphine for chronic pain scheduled for surgery, do you recommend continuing at the same dose perioperatively or weaning to a certain dose?
For chronic pain going into the OR, what do you do with it, right? I think it depends on the dose. So I think if they are at that bup for chronic pain on label 2 milligrams or less, right? Because that's, what those on label formulations are. I don't think those patients need to wean because they've got 60% or more of their mu-opioid receptors available, and it's very easy to give IV opioids or oral opioids that are going to stick to all those other opioid receptors and give analgesia. If you had a patient on bup for chronic pain that was on 8 or 16, it might make sense to have them reduce maybe by 50%, I think is some of the recent recommendation from, say, the American Society of Regional Anesthesia, I think has come out with some recommendations. Again, I think those are all very patient specific in terms of the buprenorphine, because for instance, in that patient with opioid use disorder that's unstable, it's not worth weaning that person and putting their, life, frankly, at risk. They're better off to just stay on that high dose of bup. But if you have a stable patient who can tolerate a bit of weaning, they may do better in terms of perioperative and postoperative pain control to reduce if that's not going to endanger them in other ways.
Great, thank you. And then the last question is from, they said that they work in a long-term care center and they occasionally get a short-term stay or someone on Suboxone for opioid use disorder. They also have one LTC patient on low-dose Suboxone, and their concern is about a short-term Syntax patient on multiple pain meds and a benzodiazepine.
Okay.
And I can see their question is, why, if the patient is on Suboxone as well as gabapentin, sorry, some of their questions got cut off. What do you suggest about, I'm sorry, I'm going to see if I can unmute.
Yeah, I think my chat window is small too. There we go.
Yeah, it looks like some of it got cut off, unfortunately.
Is it this one about Suboxone, Zubsolv, gabapentin, morphine, Lyrica, clonazepam?
Yes, yep.
Okay.
And I'm going to see, Michelle, I'm going to try to unmute you. So if you have a specific question, you can feel free to ask as well.
Okay. Yeah, and this could be like a good max consult too, for sure. Yeah, this is a puzzle.
Oh, okay. So I'm just looking at a guy that just got admitted. Can you hear me?
Yes.
Yes.
Okay. So I see he's on 4 C2s or C4s between his Lyrica, clonazepam, morphine sulfate, and Zubsolv. I see that he came in on the 2nd of December and that he basically was in the hospital for severe leg pain, edema. Looks like they're also finding out he has some peripheral arterial occlusive disease and probably will have an upcoming procedure here in
Okay.
later part of December. But in the meantime, I know I'm not as familiar with this formulation, this Subzolve, which is 11.4 milligram thing, but he's on that, and he's also getting the morphine 15 on top of it. They're talking about this last hospitalization. He had bradycardia that was new and persistent, which they attributed to polypharmacy. And look what he's got, nothing but polypharmacy still. So I don't know where you go with this. I wish he wasn't on all that benzo to begin with. So he's probably set in his ways pretty much. He's a bipolar guy. He's a nice guy. But I don't know how much he would be amenable to changing anything. But it looks like probably something should change if he's having bradycardia.
For sure. Yeah, I mean, I think, you know, at this dose of Zubsolve,
yeah, he takes that twice a day. Yeah.
Yeah. I mean, to me, there's, you know, I would definitely look at weaning that morphine, you know, that might be a priority, because you say like, hey, is that even doing you any good? Let's max out some non-opioid adjuncts, you know, move away from the morphine, you know, leave the Zubsolve and kind of work on these other things. And again, that Lyrica and gabapentin are sort of redundant also.
Yeah.
You know, most
high doses of both.
Right. Yes. Correct. Most prescribers will just do one or the other, not both. So, you know, I would say it's just a pretty non-standard regimen. What's this patient's mental status like? Pretty good?
He's pretty alert and oriented times 4, typically.
Yeah,
I haven't seen him this readmission. He was here just not that long ago with us, and he's a bit of a curmudgeon, but yeah, he's a nice guy, totally oriented, totally on top of his game with his care, dictating what he'll do or not do.
Yeah. And even, you know, if you were thinking about, you know, a lot of times if I'm adjusting, you know, to try to find something else effective for a patient, you know, can we take away the, you know, either the gabapentin or the Lyrica? Hey, which one do you think is helping you more? Okay, we'll leave the one you think is helping you more and get rid of the other one. And then, you know, hey, let's try, you know, a TCA at night. Hey, let's try, you know, Topamax instead of one of the membrane stabilizers that feels more redundant.
He is on Topamax.
Oh, there it is. Yep. 50. I see it now too. Good. Well, you could increase that. That's pretty low. So, you know, you could kind of talk about pushing one of those maybe.
So it looks like, as far as since he came in on the 2nd, he has used the morphine generally once a day. On Friday, looks like he used 3 doses.
Okay. Yeah. I mean, so he doesn't need that around the clock. Yeah.
But it's still okay to have that. Do I need to think about going up on the Butrans dose? I'm not certified though yet. I'm still in the process of getting all that. This is
sure.
The only reason I'm pursuing it actually is because we get these occasional patients, and nobody's around that's certified in Suboxone to sign the C2s.
Right.
So that's really why I'm looking into this. But I don't get them that often, but I am getting people more, and then I'm seeing some that, and on both of these cases, they're on it for opioid use disorder.
Right. Yeah, and that Zubsolve is just kind of maxed out. I mean, you know, again, back to that like brain picture.
I looked it up, yeah.
Back to that brain picture, yeah.
Wow, he's kind of messed up, ain't he? So the only thing that would be to wean down one of the GABA or the Lyrica and maybe increase the Topamax a little bit.
I think that would be where I would start. I don't know that I would say that's the only thing, but I think that's where I would start. And I would, you know, if I'm just imagining writing his outpatient scripts, you know, I wouldn't want to be doing his C2 with his Zubsolve. You know, I just, you know, that's a very, you know, that's a short-term thing, right? You know, if it's needed for perioperative pain or something, you know, that can be appropriate. But I wouldn't, you know, be looking to sign up to call that any kind of regular regimen for sure.
Okay. That's good to know. So you're thinking a week or 2, just while he's got this PAOD, they haven't really relieved anything. You might have to have, you know, an arterial bypass or whatever, but
right. Yes. And then exactly. And then if he has, you know, if he has surgery, then, you know, you want to think about a block and all that good stuff too.
Okay. Well, that's very helpful. Thank you so much for your time.
Okay. You're welcome. Yeah. I'm glad it was helpful.
Okay, no problem. You have a great day.
You too. Okay.
Bye-bye.
Bye. All right.
Thank
Hey,
you,
Julie.
Dr.
Okay. Do you mind if I might do a little cleanup on some of the slides and then I'll resend them to you. Is that okay?
Absolutely. Yeah, I'm happy to
Okay.
send out the revised version after. And thank you so much for a great presentation and for answering all these questions.
Glad to do it.
Yeah, thank you.
Okay. Take care. Bye.
Yeah, thank you. Thanks everyone for joining. I've included in our chat our Max phone number. So if you have any questions, you can feel free to call for a free consultation. And again, I'll be sending out these slides for your review after, and you'll be receiving your evaluation, which to receive CME or CEU credit. But if you have any questions, please feel free to reach out to me. My email will be where you received the evaluation from. So thank you.
Great. Thanks so much.
Yeah, thank you.